Wayne Parslow is the VP at Harris, and they're sponsoring this session, so I'm going to let him talk about what system suppliers can do to help address this challenge. So, Wayne.
Yep. Thank you. It's okay, I have that effect on people at home as well, even my children. Why does this seem to be so hard? That's what I'm going to talk about. I promise you, I'm not going to be here blasting and selling and doing all that kind of stuff. Hopefully, what I'm going to do is get you thinking. I'm going to challenge some of the established thinking about what we actually mean by share. Let me ask you that question. When we say share data, what do we actually mean? Right? If I get an assessment of my medical condition on a piece of paper and I hand it to you, a copy of it to you, am I sharing it? What happens when I write a note on my copy of it? Is it the same as the copy that you've got? What do we actually mean by sharing information? When I look at the BBC News website on my computer, am I looking at my own personal copy of the BBC's website? Or am I looking at the same copy of it that everybody else is looking at? I think you all know the answer, right? Are there any GPs in the room? Yeah? Do you just ask a question, do you prefer the data that you're looking at to be physically inside your own EMR, EMIS, or Vision 360, or TPP, rather than going out to the web to get it? Okay, good stuff. All right, have we got a slide up here? Let me see if we can click on. All right, so the fundamental issue that I was discussing when I started a business called CareFX just over 4 years ago here in the UK, 99% of the conversation I was having was with an acute hospital or one or other acute hospital that had a bunch of different systems across which its patient data was scattered, okay? And that problem still exists today in the acute community. So what's happened today? Why am I having completely different conversations? I can't tell you the last time I went to an acute hospital and discussed that problem, right? There seems to be something in the air. There's something going on out there that's changing the discussions that we're having. And what it seems to be is this notion of saying, well, yeah, there's a problem in individual acute hospitals that on average have got 200 clinical systems with patient data strewn across potentially all of them. But the big problem that we have tends to be regional, interagency. When we take the problem of data being scattered across multiple systems in an acute, across a community, it gets exponentially more complicated because each individual agency generally suffers from a similar problem. We're not just talking about system being in a radiology system, data being in a lab system, data being in a PAS system, data being in a GP system. We're talking about child protection systems, citizens account systems, and so on and so forth. Much, much more complicated. So this is where I'm going to challenge what seems to me, now forgive me, I am not a healthcare guy, right? My background, I'm getting on a bit now, I'm an old geezer, I was part of the sort of dot-com stuff that happened in the late 1990s. We were building websites for women, mail online, these kind of things back in the late 1990s. And I am therefore an infrastructure guy, right? What I'm interested in, generally speaking, or where I've come from, is how do you pull data together from all these different sources and deliver that information in a useful way to the right person at the right time, as long as they got the permission to see it. All right, that's my background. Now, I've been in healthcare now for about 6 years, right? I think my balloon burst or something, and I landed in the healthcare industry. And it seemed amazing to me, for example, that a business that I set up, built and sold to an American company in 1993, which did document management. It scanned bits of paper and allowed images of the paper that would normally be in a file folder to be displayed on a PC in 1993. And in 1994, when I sold that business, I thought, that technology's over, it's done, right? Nobody's got that problem anymore. Come into healthcare, what's everybody doing? Buying document management systems. It's astonishing, absolutely astonishing. So, what's the answer to this problem? Well, it seems to me the answer to this problem is get copies of the data and create a new database, which is a consolidated database from all the stuff that's in all these different systems on the outside. So we create a data warehouse. Hands up who is involved with or is aware that their organizations run a data warehouse. I would have thought it's a lot more than that. A lot more than that. Okay? So, fine, right? Okay, no problem. What we do is we suck the data out, we create a copy. But this is back to the, am I sharing data when I do this? Or am I replicating data when I do this? It's a very important point, a very important distinction. So this is the sort of conversation that I'm now having every day of the week. How do we connect primary care with secondary care, with mental health, with social services, in some cases with the police, in some cases with education? That is the majority of our conversations. So there's the answer, right? We create a replicated database. Well, actually, no, because all of a sudden we now have CSUs with multiple CCGs talking about multiple regions, and this problem is actually even more complex, if I can whiz it on, if it will whiz on, okay? Because now we have regions of organizations, each of which have different types of information stored in them, each of which say, well, the answer is, of course, because in healthcare it seems the answer is use HL7 messaging and create a repository. Now, what's the question? What we do is create a repository which is a copy of the copies that we've made, of all the copies that we've made of all the data. Okay? Now, there's a bit of a problem with doing this. In fact, there's a lot of a problem. Somebody mentioned IG earlier. Who owns this? Whose data is that? Social care data in there, mental health data, child protection information, lab results. Who owns it? So we get a problem in the middle, because I'll tell you who generally owns it. The vendor that built it. Right? I said I came from that traditional sort of infrastructure background. And in my very early infrastructure days, I will not name the company that I worked for, but you can Google me. He who owns the data owns the customer. That was what we were taught back in those days. We got him, right? You see, it would be fine if every single person used System X from vendor A, right? It really would. But they don't. Okay? So why is interoperability and integration so hard? It's because so many organizations and vendors have got little bits of vested interests in having their system as the one that expands to develop across everybody else's system, so they all become billionaires and go and live in Monaco and get a yacht. Okay? No one agrees with me on this, do they? No. I'm completely no. Okay, so 10 years ago, Pat Siebold, just a quote. They did a report on portals when, portals, this is when people were building eBay, building Amazon.com, et cetera, et cetera. What we see is going on is we are just layering more complexity on top of the complexity. We're pushing the complexity up and then trying to solve the complexity that we just created by putting a layer of complexity on top of it. Now, around about this time, people realized back in 1993, not in the healthcare space, something that I'm not sure that our industry here, and I'm not trying to knock it, this is just something, there's an observation, that replicating data isn't the same as integrating data. Okay? That's not to say there isn't value in replicating data. There absolutely is. If you want to do decision support, data mining, business intelligence, that kind of stuff, put your data in a data warehouse, and then you can mine 20 years worth of clinical outcomes based upon this demographic information versus that demographic information versus this drug being used and that drug being used. That's fantastic stuff to be able to do. But at the point of care, when a patient is sat there or a social worker is sat there and the patient is here and they need to make a decision right now, it's of very little help to do 20 years data mining and get a business intelligence dashboard. Right? They're two different problems. So back in early 1990s, the whole industry realized that you don't replicate data to create a portal or to create a real-time integrated view. How many of you think that Google HL7 messages the World Wide Web to create a repository so as you guys can search it when you... It doesn't, does it? Right? So why do we think that a portal is a clinical repository? So what they did instead was something which it seems to me, and I'm perfectly open to be criticized over this, isn't very well understood in the NHS marketplace. How many of you have heard of a SOA? Just a show of hands. Okay? It stands for Services-Oriented Architecture. Some people would say Services-Orientated Architecture, but I think that sounds wrong. Right? I'm going to spend the rest of this session going through roughly and in relatively simple terms what a SOA is and why it's relevant, we think, to enabling true interoperability across the NHS and across the care continuum. Okay? Any of you heard of the VA, the Veterans Affairs in America? Yeah? Any of you heard of VISTA? Yeah? More people than have heard of SOA. That's interesting. Right? VISTA is, to all intents and purposes, an open source EPR. Right? Think Cerner Millennium, Lorenzo, you know, that kind of capability, TPP System 1, that kind of capability, but it's open source. And it's deployed to, Patrick, help me out, what is it, 2.5 million veterans or more? More than that. It's colossal. It's on a scale that is closer to anything else to what we see in the NHS. It is open source, and it is underpinned by a services-orientated architecture. Now, what does that do? A services-orientated architecture, rather than create replicas of replicas of replicas of replicas, creates an index, effectively, which is referred to as a master index, which uses something called an RLS, a record locator service. Now, in the case of Google, a record locator service is actually people as well as technology, right? They pay for people to be trawling the web and saying, if you want to find stuff on Ferraris, you'll find it in this website. If you want to find stuff on Man United, it'll be over on that website, okay? Record locator services in the care continuum, we've implemented one of these in the south of Scotland, for example, and that's across 27,000 clinicians, 84 hospitals, and 4 completely different health boards. There is no replicated data. What it does is it knows in which systems there is information on a particular patient. It doesn't store or replicate that data. It is simply an index saying, when I search for Wayne Parslow, I know that out of the 28 systems that I'm connected to, these 6 have got information about Wayne Parslow. And it then, in real time, queries those 6 systems and builds a real-time view, just like Google, about that patient's information. Okay? Does that make sense? It's an RLS. There's no replica. This is how Google works. This is how Bing works. This is how Yahoo works. This is how the New York Stock Exchange works. It's how Amazon works. Okay? So, what is the basis of a SOA? Now, it's a bit crass, but I'm using the Lego block analogy here. Those of you as old as me will remember things called RPCs, remote procedure calls, back in the 80s and 90s, which were a question and answer mechanism to get data. If I give you a specific piece of data, you will give me a specific piece of data back. And in the case of an NHS web service, we could create a service that says, get labs, for example. So if I give you an NHS number, you will give me lab results via the record locator service for the patient whose NHS number you have just supplied. And it's locked away. Nobody knows what's going on in that thing. It's all standards-based. It's open source, open standards. But it goes off to those underlying lab systems that contain information on the patients with that NHS number and pops that data into something. It doesn't have to be what I'm showing you here. It could be anything. But fundamentally, it could be a widget, and this is important. Next one here, we build out one called Get Meds. I give you an NHS number, it finds all the medications that you might be on, whether it's primary care or inpatient meds or whatever. These are, in the case of what is generally being delivered in the market and how VA does it, for example, in America, these are Google widgets. They're open source, right? They're built using an open source toolkit. All right, is this making some kind of sense, right, from a SOA point? It's very, very distinct from the creation of a repository and then a web view of that repository. Entirely different. Okay, so now let's take it a little step further. We can start putting these building blocks together. We can string together the web services, right? So now what we can say is when I give a series of strung together sequenced web services an NHS number, they can do a little bit more for me. So maybe, whoops, wrong button. So here, I've fired NHS number, it's gone to the PAS system and got me the demographics. Now, it will go to perhaps EMIS or System 1, and it will get me recent encounters or problems, okay? The services via the RLSs know where to go to get the data. And from these individual open source web service-based gadgets, we can start building clinical views. From that, if more and more organizations, more and more agencies were able to build these services that were then able to be published to a services registry, what we end up with is like an NHS yellow pages that is electronic. Meaning, instead of just searching, you know, I described in Scotland, if you search for Wayne McParslow, it will search the 27 systems, or it will search the relevant systems. In this sense, you put in Wayne McParslow, and what it's going to do is go to the services registry for every single agency in the country that has published a web service to this registry, and it will know where to go to get data about Wayne McParslow. This is not rocket science. This has been done. It's been being done for the last 10, 12, probably a little bit longer than that, outside of the healthcare industry, whilst we've been spending billions on EPRs or EHRs. All right? So now what we have is this composite view of information from wherever it resides based upon open standards and open source componentry. And the more widgets as an industry we were to create, could create, the more flexibility we've got. Now, I'm just showing you here a few of the widgets we've built from within our own portal architecture. They're still Google, right? But you can all go to Google, you can download Google Web Tools, it's open source, and you can build this stuff yourself if you've got the skills or you want to teach yourself or you already know how to program. Okay? That's an example of, here, a care team management widget that we've created. Here's an example of a set of clinic lists. So all this is doing, web service to PAS system, show me today's clinic, I'm Dr. Smith. Show me today's ward list, show me today's outpatient list, yeah? Show me today's list of patients in A&E. That's all this is, it's a Google widget, right? Next one, out to the patient. Okay, we talked about we talked about reluctance issues a little earlier. We touched upon, you know, IG reluctance issues. I won't name the customer, but we're deploying, these are some of the views we're actually deploying to the patient for one of our customers at the moment. And one of the doctors actually a couple of the doctors that are controlling what the patient can see kind of thing, described that they wanted to implement a 4-second delay. You know, like you get on the TV in case somebody uses a profanity. So before the data gets into the portal, they can strip out this bloke's just a hypochondriac sort of stuff, you know, before it gets out to the patient. It's quite funny. So just examples. That, www.century.com, they publish the gadgets. Everybody builds these. They're like apps. So don't get confused between apps and what I'm talking about here, right? Apps are proprietary. Apps run on your iPhone. They're designed to run on iOS or what's the other one? You know, ice cream sandwich or jelly bean or whatever those things are that are out there now. These things are very different. What we're talking about are the individual widgets. There are thousands of pre-built widgets, open source, free, that are sitting there waiting to be connected to a web service so they can display meaningful data out there. Okay, these aren't ours. This is the open. This is just one tiny, tiny pinprick of the thing. You know, you can see drop-down lists here, checkboxes, visual charts, flow sheets. You know, however you want to display this data, all taken care of for you. Right. This is the holy grail from where I stand, and I would like to think from where the guys on my right here stand now. If we were to engineer a culture of the creation of open source and open standards-based services, we could then move into a realm which really will start to benefit the patient and the outcome. And that is the ability to start building our solutions from the pathway downwards. Define first what the pathway looks like, right? In a visual flow. Patient arrives, thrombolyze patient within 45 minutes, apply anticoagulants, you know, all this stuff that's out there and defined as map of medicine, all these kind of things. But instead of it being a map that you read physically on paper, turn it into a sat-nav. So at the various points in the pathway journey, we know which web service to call, what data to display to the user that is looking at, or the clinician that's looking at that information, and take them through a process. Patient arrives in A&E, register them. Here's the screen you need to do that. Now present the integrated information you're going to need to make an informed decision about that patient. Now, based upon what we hear, present a couple of possible decisions to that clinician, and then at the end of it, automatically order the appropriate tests, medications, or admit the patient or refer the patient and automatically communicate that to the GP. And when you take this to its ultimate role, interagency, we can actually start to automate these processes by pathway down to web services across agencies without actually having a single monolithic system that has to be plunked on top of all this kind of stuff. Okay, am I at the end here? Final slide? Okay, so there is a religious argument going on out there. Do I do an EPR or do I do interoperability in a portal? How do I interoperate? Do I throw out all of my old systems and put in a new system to sit on top of it? Should everybody adopt the system I have so I can communicate? Honestly, I think as an industry, we're going to end up doing pretty much both. Whatever one does, whatever Acute decides to spend 50 million on a new EPR, they will end up also doing interoperability and integration. The same will be true of communities, the same will be true of social care. The reason is because one system can never do everything. It can only do what the vendor built it to do. This is a framework idea, not a product idea. Why are we always going to need a middle layer? I'll just finish with this. Any organization, I'm saying here, can be broken up into 4 key components. At the very top, every organization out there has a strategy. Okay? What do we think the change cycle is for a strategy? This is our strategy for the next 12 months. We're going to do this much in revenue, or we're going to treat this many patients, or we're going to have this number of reduced readmissions, blah, blah, whatever that strategy is built up of. The change cycle for an organizational strategy is about 1 to 2 years. Yeah? Organizationally, we put an organization in place to support the delivery of that strategy, right? For the next 12 months or the next 24 months, whatever it is. Unfortunately, that has a change cycle of 3 to 6 months. Because after every quarter, when it doesn't work, we tweak it. And we put that person there, and this guy in charge, and that guy goes over here, and we organizationally change it. What do you think the change cycle is for software and hardware infrastructure, you know? Mission critical software in healthcare? This can't possibly adapt to a dynamic, changing set of requirements at the top end without having some kind of middle layer in place. And what I'm proposing is it's time for the NHS to start thinking truly and properly about a national services-orientated architecture strategy. And I'll shut up now. Thanks very much for your attention. Thank you.
All right, we have time for a few questions, so we'll just open it up straight away if anybody has questions to Wayne or more questions to the panel as well. We have one question over there, please.
Hi, Antonia Robson from Central Eastern CSU. Thank you very much for the presentation. It was really interesting, and I buy what you're saying in terms of the kind of addressing the technology kind of side of things and the barriers. What about the sort of IG and privacy side of things? Because that's my concern here is if you can make it work technologically, can we make it work from a sort of IG privacy perspective?
I'm in grave danger of probably coming across a little flippant in that regard. I'm going to say it's an age thing as much as anything else. If we look at the attitude of those, let's say, up to the age of about 40, so I'm looking at my wife here who tweets and face twits like crazy, and you know. There's a very, very different view of privacy amongst the demographic young today. And I think that is going to change entirely the landscape. I suspect that once we start to make clinical records available to the patient, such as we were talking about here with the patient portal, the situation with the 4-second delay that I was talking about earlier. As that information is being made available to the young, I'll give it a nanosecond before somebody's lab results are on Facebook. The whole landscape is going to change. I really am not trying to belittle what it is that you're saying, and it clearly has to be thought about very carefully in terms of consent, who can see what, but that can be modeled within systems. If it can be modeled in people's heads, you're not allowed to do this, you're not allowed to do that, it can be modeled systematically as well. So, within these environments, and I didn't go into the detail, you have things like consent modeling, legitimate relationship modeling. Yeah, these are the people involved and the structure of the people involved in the care of this specific patient. In order for them to look at this record, they have to have either a straight pass-through, or we put what's called break the glass functionality in front of the user, which says, why are you looking at this patient? We do not see there is a legitimate relationship, in which case a reason is given and audited. And I would argue that in those circumstances, without that kind of system, we can't audit that kind of access very easily at the moment. How many medical records are faxed from one place to the next where you really can't guarantee who's going to pick the piece of paper up at the other end? So, as I say, I'm not trying to belittle it, but I think it's an unstoppable locomotive that's going to have to be watched carefully, but it shouldn't get in the way of progress.
Any thoughts from the panel on the IG? We touched on it earlier as well, but no. All right. One more question. Anybody? It's down here.
Hi, Pete Mosley from Greater Manchester CSU. The service-oriented architecture meets the patient in front of me treatment sort of scenario right now. What about the business intelligence side of things and the data mining that we need to do? Can we use the same sort of architecture to get that result too?
Yeah, you can. It's different in that what I was talking about more was a point of care scenario, right? So you've got a social worker, they've got a mobile device, the patient's there, you don't know why they've got a temperature of 39.8, right? With data mining, there are all sorts of standards, and I suspect you probably know this, around how you can query data warehouses in order to produce meaningful data. And if you go to that Accenture.com site, you will see gadgets that are presentations of dashboards, dials, bar charts, dynamic views. However, something that really, really excites me is where I ended up with that presentation in terms of process, pathway-driven solutions. Because with a pathway-driven solution, you're capturing data in real time. As each individual hospital or hospital community is going to have a number of individuals with long-term conditions, for example. So they will have gone through a pathway which might be a cardiac pathway and then out into the community because they need continued care and physiotherapy, and maybe they've got diabetes, all these kind of things. With a pathway-based solution, you're going to capture the events as they happen, the reasons why those things are happening. You're going to be able to see at any point in time what's going on today. The fact that if 3 more patients arrive in A&E, you're going to breach your target, right? Whereas what I see of BI, and don't get me wrong, I think it's fantastic stuff, and I don't think we've scratched the surface of it in terms of certainly predictive analytics and things like that. But with this, when I'm driving my car along, I don't want to see what the temperature of the engine was last week. I want to know it's going to overheat now. And that's, I think, what BI written around pathway, live pathways is going to give us. That's of huge value. Yeah.
All right, thank you very much, Wayne, and thank you to the panel. So hopefully you can all join me in thanking them for their time and their contribution today. All right, and that's it from us. Next session is coming up, I think, so thank you.